Um, a very good afternoon to you all. Am I audible?
Yes, ma'am.
Yeah. So, good afternoon. So today we'll talk on a very important topic, that is needle stick injury and its post-exposure prophylaxis. See, this is again a very important topic because I think all of us has 70 to 80% of us might have experienced one or two incidents, such types of incidents in our lifetime. So without wasting time, let's proceed. So what we know, it's actually a needle stick injury. We all know we are the healthcare workers. We are always at a potentially exposed to various bloodborne pathogens. There is a huge list of these bloodborne pathogens, among which three are very important. Among which three are very important. That is, among the viruses, if I talk about, it's HIV, hepatitis B, and hepatitis C. Now, when we talk about such needle stick injuries, following any episode, any incident of this such needle stick injury, the two main important things are how you have managed the case once such incident has happened. So that is a post-exposure prophylaxis. Whenever there is any injury, whenever there is such kind of incident, so how you have managed the case, so the chances of acquiring such infection following such exposures is much minimal. So what do you mean by an exposure? So exposure means whenever there is any percutaneous injury, where either we have got some cut from the sharps, from the needle, or any scalpel, whenever any body fluids or something like it get spilled on our mouth or on the eyes, that is our mucous membrane. And whenever there is any contact of the patient's body fluids with a non-intact skin, and even if the skin is intact and the duration of exposure is very long, so all these categories, these are all fall under the exposure. Now, what exactly is a needle stick injury? It is anything, any penetration of any sharps into our skin, into a healthcare worker, and that sharp or needle should have been in a contact with the blood or the body fluids of the exposed person. So that is a needle stick injury. So who all at risk? All the persons who are working in a hospital are at a risk. That includes, being a doctors, being a nurse, being a PG students or the SRs, or even the general duty assistant, or the persons who pick up waste. They all of them ABT technicians. So everyone who is working in a hospital are at risk of having such incidents. So, as I told you, hepatitis B, HIV, and HCV are the three most common viruses. And what are the potential risk of acquiring such infection following any needle stick injury incident? So, the highest is with hepatitis B, where the risk of acquiring the infection can ranges from 5% to 30%. Different studies have quoted. Followed which is hepatitis C virus, where the risk ranges from 1% to 7%, and the least among is this HIV. So we are very much worried of HIV, but the risk of acquiring the infection following a needle stick injury is the least with HIV and highest with hepatitis B virus. Now, what are the body fluids which should be considered? Ideally, all the body fluids of a patient should be considered equally at risk. However, there's various specimens like blood, semen, vaginal secretion, or any of the sterile body fluids, ascitic fluid, synovial fluid, pericardial fluid, or amniotic fluid are considered at a very high risk compared to the samples like tears, urine, feces, saliva, sputum. However, they are considered at lower risk only at point when there is a no visible blood. Once you have a visible blood in any of these specimens, so they are equally at a risk of acquiring any infection. Now, when we talk about the epidemiology, what exactly is the epidemiology of these needle stick injury? What exactly is the as per the CDC estimates, they say that approximately 4 lakh sharp injuries occurs annually. But whatever the data is presented to given by the CDC, it is just the tip of the iceberg, as majority of the cases do go unreported. When we talk about the data which is available from India, or so they say ki NSI incidence may vary from 15% to 70%, but again I'll say it's just a tip of the iceberg, because majority of the people, they don't even report to their superiors that the such kind of incidents occur, either because of a fear or because of hesitation and whatever it is. But yes, majority of time it goes unreported, it goes undocumented. So the true incidence of needle stick injuries is yet we don't know. Now, when we talk about the India data, very limited studies has been conducted in the various parts of India where they have talked about the incidence of needle stick injury and what are the and the various schedule of the exposed persons. Now, this way varies depending upon the different institutions, depending upon the type of the studies they have conducted. And when we talk about in Delhi, specifically healthcare workers and PGI and they, the again the depending upon the type of the sample size they have taken, what all the histories they have included in it, that also varies. Now, this can be so what are the various other factors which can lead to the risk of the infection? That will vary. The type of the body fluid with which we have got the exposed, how much amount of the body fluid or the blood was there, type of the needle which we were using, how deep the injury is, what is the status of the source, that is from the patient where we have got this injury, and how appropriately and timely we have managed this episode, and we have started the post-exposure prophylaxis. So that will all depend upon the various factors. These are the factors which will further decide what is the percentage of chances of acquiring any infection following such exposure. When we talk about the various practices which can lead to a very common practices which can lead to such incidents. So number one is recapping. Again, whenever you try to recap the needle, this is the one thing where most majority of your needle stick injuries has been occurred because of all this recapping, where they try to recap after taking the blood sample or anything after delivery of any antibiotics or something like that. Second is the when the most common practices is like if you keep on throwing your sharps in the needles anyway, just like that, when they are not being properly disposed of as per the biomedical waste guidelines. So again, this is again an important factor which is commonly encountered when we try to find out what could be the root cause of such incidents. So what happens? Okay, if a needle stick injury occurs, as I told you, post-exposure prophylaxis, this is a multifactorial. It is a multi-steps, so which includes various steps. First of all, the first step, whenever any needle stick injury occurs, the first thing you have to provide is the first aid. You have to provide the first aid. What are the immediate steps which has to be taken care of following such incident? You have to immediately report it to the superior or your senior, whatever the hospital. Every hospital has their own policies, whom to inform. Third is we have to assess the risk. What is the risk? How it happened? You have to inform, and you have to take that consent from both the exposed person as well as from the source, that these are the things we are about to carry out such as types of the test, and we have to evaluate what is the status of the exposed as well as the source person, whatever depending upon the laboratory investigations, what all the steps which now you have to initiate for the prevention of acquiring such infection. Apart from that, follow-up of such exposed person is very important. And the least but not most important point is documentation of such incidents, which is again a very crucial step. Now, whenever we got any exposure, any needle stick injury, first thing is thumb rule is never panic. The more you panic, the more chances are you are going to do the mistakes. Anything, suppose if there is an injury with a sharp, first of all, if you're wearing the gloves, remove the gloves, wash it out with the soap water in the running tap water. Never try to squeeze it out. Never try to, put your fingers immediately in a habit of putting it in your mouth. Never try to apply any of the disinfectant. So these are the few things. And suppose if there is a splash in the mucus in the on the mouth or in the eye, so what you have to do, you have to immediately again wash your face and the eyes area with the running water. After this, immediately you have to report to supervisor or the senior, whatever the institute have their policies, whom to inform. But information report to the senior is again very important. After the risk assessment occurs, means what type of the injury it is, whether it is a mild, whether it is moderate, or whether it is a severe. Mild means whenever there is a very small, whenever there is a splash on our mouth or the eyes, or when there is a contact with a non intact skin with, and we have a very small amount of the blood visible to us. And moderate means a mucous membrane but non-intact skin with a larger amount. And or we can have a percutaneous injury, that is an injury with any of the sharps. And severe means whenever there's a percutaneous injury and you are able to see the needle has been contaminated with the blood or the body fluids. Now, once after that, you have assessed what is the risk, whether it is mild, moderate. You have to provide us. You have to provide a counseling to your exposed person, to your healthcare worker. You have to make it very sure that first thing is psychological support. They should not panic. You have to make them rely their anxiety. Okay, see, yes, it happened. This is the your risk, and you should make it very clear to the person that yes, incidents happen, but the chances of acquiring infection following such exposure is such minimal, or how much it is. You should tell him yes. If we start, how important the post-exposure prophylaxis on timely when it started timely is so critical, so as to prevent acquiring such infection. Suppose if you have started on medications in the case of HIV, now the drugs which has to be given to you, it should has to be taken for the whole duration recommended time period of time. Like in HIV, it is 4 weeks. Just when you take such types of the drugs, there are the certain side effects, but you don't have to withdraw the therapy in between. You have to follow up you have to follow up the guidelines. You have to follow up the instructions which we are providing to you throughout the course, and you should also ask them to avoid any sexual intercourse and the pregnancies following the exposure for at least 6 weeks. Now, the next most important point is what are the status of the spouse and as well as for the source person. Now, for source person, that is our patient, yes, for HIV, HPV, and HCV viruses, we do the testing. For hepatitis B, we test surface antigen. For HIV and HCV, we test the presence of antibodies. Now, in the exposed person, what we'll do? In the exposed person, apart from HBS and HIV and HCV, we also test the anti-HBS titer of the healthcare worker. And remember, as a thumb rule, whenever you are doing any HIV testing, informed consent from the exposed person, source person must always be taken. So what happens if you have got exposure with HIV? So now coming to each HIV, hepatitis B and hepatitis C viruses. So the most important step with HIV is that you have to act immediately, because there are the certain drugs, fixed dose combination drugs are available. The post-exposure prophylaxis drugs has to be started, and ideally it should be started within the 2 hours of such incident, and the maximum time they can be given is up to 72 hours, because beyond the 72 hours the studies have conducted and they've shown that these drugs are not as effective in preventing the infection if given beyond 72 hours. So the for HIV time is very critical. In NSI, whenever the testing is required, so everything is critical. The sample collection of the sample, to the sending of the sample to the laboratory, and getting the test reports from the laboratory. So everything should be in a very fast manner. There should not be any delay in getting the test results. So the hospital must have such a facilities that such kinds of reports, such type of the critical reports should be communicated to the clinician or to the in charge on a well on time. Suppose if the person, and there is a drug fixed dose combination of the drugs are given for the HIV prophylaxis, this which includes tenofovir, lamivudine, and dolutegravir, and this has to be continued for 4 weeks. Apart from that, the person should be followed up for anti-HIV at 3 weeks, at 6 weeks, and 3 months and 6 months for the detection of HIV antibodies. Now, what happens with the hepatitis B virus? If there is an exposure with hepatitis B virus, so the ideal time at which we should respond, it should be within 48 hours, and maximum it can extend up to 7 days. So this is the time limit where we have to respond if there is any needle stick injury from a hepatitis B case. Before going into the detail, the basic concepts should be very clear as far as hepatitis B vaccine is concerned. We all know we have hepatitis, a very excellent hepatitis B vaccine, which is given intramuscularly, and 3 doses are given at 0, 1, and 6 months of time. When we provide these 3 doses of the vaccines, after which we check the presence of anti-HBs, means a body should start producing immune response to the vaccine which we have given to a healthcare worker, to any person. Especially here talking about the healthcare worker. So what is vaccinated? So an anti-HBs titer more than 10. If the person is having an evidence, a documented evidence that is anti-HBs titer is more than 10 after completing 3 doses of hepatitis B vaccine, that means the person is immunized. Please understand there are the two different terms, vaccinated and immunized. They are not the same thing. Vaccinated means you have been given the 3 doses of hepatitis B vaccine. And immunized means you have been given the 3 doses of hepatitis B vaccine and your body has generated anti-HBs titer, which is more than 10 milli-international unit per ml. That means you are immunized of acquiring hepatitis B infection following any such kind of incidents. So, based on this, the healthcare workers can be classified as a responder or it can be a non-responder. Responder means when you have given 3 doses of vaccine and anti-HBs titer is more than that, 10 milli-international unit per ml. Non-responders means even after giving 3 doses of hepatitis B vaccine, your anti-HBs titer is less than 10. So what you will do, you will again give 3 doses of hepatitis B vaccine again. So second आप cycle फिर से चलाएंगे. So you will give in a total would have been given 6 doses of hepatitis B vaccine, but still your anti-HBs titer is less than 10. So such type of the patients are known as non-responder. As the name indicates, they are not responding to the vaccine which has been given to them. And apart from hepatitis B vaccines, we do have an immunoglobulin. Immunoglobulin is given again intramuscularly at the dose of 0.6 ml per kg. Remember, I told you anti-HBs titer should be checked. So the ideal time of getting anti-HBs titer is only after the 3rd dose has been completed, and the minimum time between the 3rd dose and the time you are getting yourself tested should be at least 1 month. At least 1 month minimum time should be there between your last dose and the time when you are getting yourself tested for anti-HBs titer. So based on these factors, now what will happen if you have got any exposure with hepatitis B case? Suppose. So now it will fall up into the various categories. So what are these categories? Suppose your healthcare worker is a responder, is a vaccinated, and you have an evidence that his anti-HBs titer is more than 10. So whatever your source is, whether the source is HBsAg positive or negative, no action is required because your healthcare worker is vaccinated and he's immunized also. So anti-HBs titer is more than 10. So nothing will happen. So no further action is required in such cases. You just have to allay the anxiety of the patient, of this our healthcare worker. See, you are vaccinated, your titer is more than 10, nothing to worry about. But please be very careful while you are working. And try to find out the root cause of such incidents, why it's happening. Or another situation can be your healthcare worker is a non-responder. Even after the 6 doses of the vaccine has been given to him, your healthcare worker is unable to generate anti-HBs titer more than that of 10. So what to do? If the source is HBsAg negative, then no further action is required. And if the patient from which he got this injury is hepatitis B positive or we don't know the source, at that time, immediately to prevent the acquiring of such infection, what you will give 2 doses of immunoglobulin 1 month apart. See, remember, as this healthcare worker is a non-responder to the vaccine, he has got an exposure, he has got such incident from a hepatitis B positive patient. So, to prevent the chances of him acquiring the infection, immediate action, what we have to do, we have to give him immunoglobulin, and the second dose of immunoglobulin has to be given 1 month apart. So remember, 2 doses of immunoglobulin 1 month apart. Now, there can be the situation when your healthcare worker is vaccinated, he has completed 3 doses of the vaccine, but he does not know his anti-HBs titer. At that point, as I told you earlier, we will find his anti-HBs status, anti-HBs titer. Suppose the titer is more than of 10 milli international unit per ml. Irrespective whatever the source is, no further action is required. You don't need to be panicked. The healthcare worker doesn't need to be panicked. He is immunized. He is protected against acquiring the hepatitis B infection. Suppose if the sources turn out to be hepatitis B positive and your healthcare worker titer turn out to be less than 10. Now, if the source is positive, to provide immediate protection for that particular period, you will give him 1 dose of immunoglobulin, right? And as the titer is less than 10, you will ask him, please, you start taking doses of hepatitis B vaccine at 0, 1, and 6. Hope this is clear because he has completed already 3 doses, but his anti-HBs titer turned out to be less than 10. And now our source is positive. Immediate protection here, we will give him immunoglobulin. Immediate protection is immunoglobulin. Now we have to protect him further also. Our aim is that all the healthcare workers should have anti-HBs titer more than 10. So we counsel him and we guide him, please, you take your remaining, again you take your 3 doses and again get your anti-HBs titer checked. Or suppose if your healthcare worker is less than 10 but source is negative, so immediately you don't require anything, but again you will counsel your healthcare worker, see your anti-HBs titer is less than 10. This time the source is negative, so nothing to panic about, but might be in the future you can get pricked by some HBsAg positive patient. So you have to protect yourself, get yourself vaccinated, take another 3 doses of the vaccine, and again get your anti-HBs titer checked. Now, suppose your healthcare worker is either unvaccinated or he has taken 1 or 2 doses and or he refused. So what if nothing, if the source is negative? So again, we have to consult, we have to provide training to a healthcare worker. We have to make him realize the importance of this hepatitis B vaccine, how excellent this vaccine is and how you will be protected in your whole life. And suppose if the source turns out to be positive and whether he's unvaccinated or incomplete, so for the immediate protection, give him immunoglobulin. And if he's not vaccinated, you please ask him, please you take the further vaccines. If he's like suppose if he's taken only 1 vaccine and this incident happened, then you will advise him to complete your further 2 doses of a mixed vaccine. So again, our main motive is all the healthcare workers should have taken the 3 doses of hepatitis B vaccine. All our health workers should be 100% vaccinated and the anti-HBs titer, and you should have a documented evidence of the anti-HBs titer, and the titer must be more than 10, so as to prevent such risk of acquiring infection in the future. Now coming to whenever the source turn out to be hepatitis C, unlike HIV and hepatitis B, where there are very specific guidelines, these are the things to follow, these are the things to do. When we talk about HCV, as such, there are no specific guidelines. There are few recommendations what can be done. So lots of pool of thoughts is there, lots of controversies there, what to do, whether you should give a post-exposure prophylaxis or whether you should just treat him just like a case of HCV infected cases, or what is again thousands, there's different school of thoughts. So what exactly happens is, suppose if the source is non-reactive, antibodies to HCV is negative, then you don't require further action. However, if your source turn out to be anti-HCV reactive or it's unknown, what we'll do, we generally ask this, we try to know the HCV RNA status. We want to know whether the person has been having a viremia or not. So what we advise you have, then you will get the HCV RNA testing from the patient. Now what about the healthcare worker? Healthcare worker will be in anxiety, usko anxiety ko usko काम करना है, and then what you will do, on the first time you will get his anti-HCV done. Anti-HCV, so that you will have a document evidence that this your healthcare worker has not been previously exposed to hepatitis C vaccine. Sorry, hepatitis C infection. So first of all, immediately you will get your anti-HCV done, antibodies done. After this, what you will advise him, see, suppose if there is any chance that you might have acquired the virus into your body following any this little stick injury, you will see, so the virus will enter in our body and will start replicating. And it's generally 2 to 3 weeks when the virus start replicating. So you will advise the healthcare worker to get HCV RNA testing done at 2 or 3 weeks following the exposure to such incident. We might pick viruses, or suppose in case you have missed or have been suppose, or you can say ki viremia was a shorter duration, we couldn't pick or something like that. Then at 1 month, suppose if the healthcare workers had acquired, then definitely there will be the generation of antibodies. Antibodies generally start appearing in HCV infection by 3rd or 4th week of infection. So you will advise the healthcare worker to get antibody testing done at 4th week, that is 1 month following the exposure to the needle stick injury. Then further, you will ask him to get anti-HCV testing done again after 6 months of such exposure. Meanwhile, you will also advise your healthcare worker that if you develop any non-specific symptoms which are, compatible with the acute HCV infection, you should always immediately refer to a hepatologist, and you should always get yourself evaluated. So hope it's clear. Whenever the source is positive, get anti-HCV done with the baseline from the healthcare worker. Then you look for HCV RNA 2 to 3 weeks following exposure. Look for the production of any antibodies at 4th week of incident, and after that 6 months following the incident if it becomes a chronic. So these are the time checkpoints for the for a needle stick injury following exposure with a known case of hepatitis C, chronic hepatitis C. So now what's the, there's a lot, as I told you, there's a dilemma whether we should start post-exposure profile if they are directly acting antiviral therapies are available, they are excellent drugs. So should we, just like HIV, when we give post-exposure prophylaxis for 4 weeks, so should we also start giving it for hepatitis C? So there is lots of controversies, lots of answers remains, unanswered, questions remains unanswered. What to do? So first most is pathogenesis and the time course. Unlike HIV, when we know that the virus will enter the body and the virus will not cause systemic infection till 3 to 5 days, once it enters. Like in HIV, we know it very clearly. So that is a basic funda why we give the post-exposure prophylaxis must be given within the 72 hours, because systemic infection will not cause within 3 days following exposure. Unlike in HCV, we don't know such clear-cut kinetics. What is a kinetics? We don't know the time when it enters in the body, how much time immediately it will enter to the liver and it start, replicating in the liver. Such kind of kinetics, such type of pathogenesis is still not known for hepatitis C virus. Second important thing is, even if we know, then the directly acting antivirus, the therapies which are available, they are the ones which inhibits the replication of the viruses. So right now we do not have any, and this hepatitis C virus spread so quickly in the liver and start destroying hepatocytes. So we do not have right now any first we don't know how much time will it enters and will start, affecting our hepatocytes. Secondly, we do not have any drugs which will which will inhibit the entry of the virus into the liver. So that's again a point. Third, what can be the efficiency when we give these directly acting antivirals? What should be the duration of the therapy? Whether it should be like HIV should be 4 weeks, or it can be 6 weeks, or it should be like a normal hepatitis C infection, they should be treated for 12 weeks. and is still not known. And the fourth is, what is the cost effectiveness? Even if we make a guideline that no, following any exposure, you should start post exposure profiles for hepatitis C. Then what is the cost effectiveness? See, the chance of acquiring hepatitis C infection following an exposure is like 1 to 2%. Some studies have shown up to 7%. So if you start giving directly acting antivirals to all the persons who has been exposed, who has got such incident, amount you as compared to the percentage of chances of getting such infection following exposure is very less. So the amount which we'll be spending, then again, is the post exposure profile cost effective? Again, it's a doubt. So still, some people still, as such, there are no guidelines. Even after having such a excellent antiviral therapies which are available, still we don't know whether we should start these all exposed persons with the directly acting antivirals or not. So once you have, you know the status of its source, you know the status of exposed, you have given, no, now this is the things now you have to do. Now the follow-up of this exposed person is again very important. Like in HIV, I told you, it should be followed at 3 weeks, 6 weeks, 3 months, and the 6 months for HPSAG. Similarly for HIV, this should also be followed. HCV and for hepatitis C, I've already told you. They should be again followed up for 6 months for the presence of any anti-HCV. Any further derangement of the LFT should also be seen, should also be looked upon. Any kind of non-specific symptoms, if the person develops following exposure within the 6-7 months, then again should be taken into consideration. And and again, important point, if you have started the hard therapy, post-exposure profiles for HIV, that treatment must be continued for 4 weeks, and your healthcare workers should not withdraw the therapy just because of the side effects. The next most important point is documentation. Whatever the incident has occurred, how it has occurred, at what time it occurred, and what all recommendations which you give to your exposed person based on the laboratory investigation of source and the exposed, everything must be well documented. Now, what are the various ways where we can, prevent this needle stick injury? Again, the most important is our training. One should be very much trained. Your healthcare worker should be trained about what are your safe injection practices. Your nursing staff should be trained, and all the healthcare workers should also be trained how to throw your sharps and such syringes, where to throw them, never try to recap them. So these are the very small things where the training should be imparted to all the cadre of the workers which are working in a hospital. Apart from that, there are the certain safety engineer devices where you can have some, whenever you're trying to take out the blood after the single use, either some plastic, it get covered by a plastic cover so that the reuse of the needles is not done, recapping of the needles is not done, or they can be covered up by the blunt end. Sharp end के बाद बस उसका blunt end आ जाता है, so that again the chances of pricking is minimal. Like in ILBS, what we are using is we are collecting the we are collecting the blood, and then once we have collected the blood, we used to close this needle with the help of this plastic cap. So once you have collected the blood, you will just plug this plastic over the needle. So what will happen? This will not be open, and even if you throw it somewhere like that, so it will not get pricked by. So the prick will not happen because it has been already covered up by the plastic cover. So, or again, use of such safety engineering devices along with the continuous training. The studies have shown that there is a significant reduction in the needle stick injury. Now, this is we do have at ILBS, we do have a needle stick injury blog. We have a website where any doubts, any queries related to needle stick injury can be asked there. And this is our needle stick injury form whenever any injury occurs. So this is the form where the detail for the source exposed is generally taken, is documented. And at ILBS, we are also following the pre-exposure prophylaxis, means at the time of the joining, all the healthcare workers have been screened. They have been asked whether they have taken hepatitis B vaccine or not. If not, then the vaccination is provided to them. And we also check the NTH titer at the time of her joining. And based on the NTH titer, based on the our vaccination history, appropriate actions has been. We do take appropriate actions. So in conclusion, I would like to say neurologic injury is again a very common and important occupation is injury. Timely initiation of appropriate post-exposure prophylaxis again is the most important critical step in preventing the acquisition of the infection even after following such incidents. In India, there is a lack of the national policy. We do not have such a good national policy. ILBS, we are having both a very good stringent. We follow pre-exposure prophylaxis as well as a post-exposure prophylaxis. And another important point is everything you have done, everything you have documented, but even if you're a healthcare worker, you are not following it, if you're not monitoring it, then all your efforts goes into vain. So, and most important, and depending upon your hospital policy, every healthcare worker, every hospital staff must know whom to contact, where to contact when such type of incidents happen. So with this, I end up my lecture.